So I have a gentleman in his 70s who presents with 3 days of confusion, some intermittent chest pain and fatigue, comes to the emergency room and is found to be hypotensive. He has a past medical history of poorly controlled insulin-dependent diabetes with his most recent hemoglobin A1C around 10, some GERD, coronary artery disease, heart failure with preserved ejection fraction, mild COPD, and hypertension. You draw some labs and get the following labs. So we will have labs several different times, but this is what we're going to discuss. You're in the emergency department, so Travis, this is your safe zone. He has a sodium of 133, a potassium of 8.1, a chloride of 92, a bicarb of 7, BUN of 82, a creatinine of 10.1, a glucose of 184, and a normal calcium. And we because he's at a place where we have a computer access, we look and see that 4 months previously he had a creatinine of 1.6. Okay, so what I see is Travis, so unmute yourself, Travis. You want an EKG. Will the EKG change anything that you do?
Probably not. Maybe just make me feel a little bit better that it was done, knowing what we are likely going to do anyways.
Right.
But if there's something there, then obviously it makes it a little bit more emergent.
So as I picked this guy up after he was transferred from intensive care, which is he was transferred after 8 or 9 days in intensive care. I tried to look through the chart to find out exactly all the details of his presentation. All I can say is that there was not any alarm signs in his EKG, and his bladder had very little urine. So Chioma, you make the great observation that he had an anion gap of 34. When you see an anion gap that high, what does that tell you? Problems. Chioma, do you have any idea what an anion gap that high tells you?
Maybe he's like really dehydrated, has a high lactate or something.
So we would think of diabetic ketoacidosis. I can tell you he's not on an SGLT2, so his glucose is not high enough for that likely to be ketoacidosis. So we think of ketoacidosis, and then you're 100% right. You'd think about lactic acidosis. They do get lactate level, and it's 8.3, which is high in our emergency department. So he does have lactic acidosis. So correct. Is that Thiago who's 33, 66, 99?
I don't know who I am. I don't know why. Let me change it. It's the password to enter in this meeting. I don't know why.
There's a password for the meeting, and then they wrote down. Okay, so Travis, you work in the emergency department. So tell me what you would do about his potassium in the short run. So immediately in the emergency department, what would you do? And then what would you do after that?
So first thing I would do,
remember, he is hypotensive.
well, first thing I probably would do is, I mean, if he's hypotensive, he needs fluids and, 2 large bore IVs, would want to see what his urine output is. See if he has a full bladder, see if he's got hydro, because that's a reversible cause of that, hyperkalemia and renal failure. And then I would go to my medications for hyperkalemia, which is like 20 milligrams of albuterol, insulin, glucose. Usually it's an amp or 25 grams of D50, along with 10 units of insulin, making sure that we have like a Q30-minute AccuCheck in place for that. And seeing how he's got a low bicarb and the high anion gap, he likely would benefit from a bicarb drip. So I would take probably 3 amps in D5W and put it 125 an hour.
Okay, I'm going to argue with you on the bicarb.
Okay.
Just because I like to argue, and now this is it depends upon the pH, and I do not have a blood gas, but many experts, many nephrologists will say that you don't give bicarb unless you think the patient is in so much distress that it's dangerous to not. And some say below 7.2, some say below 7.1, some say below 7. I do not have a blood gas or a VBG on him. So I think they just went with the routine things. Drew,
our hospital, we use 7.2 because there's bicarb shortages everywhere. So you're right. VBG or ABG, you could go with a VBG. You don't unless you were really needing to look at his PCO2. But that would really be if he's 7.3, 7.32, he doesn't need bicarb. I agree with you.
Yeah. So and there are many nephrologists who think that you go down to 7.1 or even down to 7. And the reason is if we can treat his underlying lactic acidosis, which is probably due to his hypotension, then it's likely going to correct by itself. And if we give him bicarb, we might overshoot. Now it's different if it's a normal gap acidosis. So that, and I've said this before, but I think this is really important. You always give bicarb for a normal gap acidosis. You try to avoid giving it for an increased anion gap acidosis. So anyway, what they did is they treated his hyperkalemia, they documented lactic acidosis, and they called renal. Why did they call renal? Because he has an absolute indication for dialysis, right? Hyperkalemia with a creatinine of 10.1, whatever the reason is for the creatinine of 10.1. Now, because he was hypotensive, there was a concern that this was probably acute tubular injury. When I looked through the chart, they did not document looking at the urine. There is a urinalysis that has specific gravity of 1.020, suggesting that the kidney was concentrating at that time. They did not send off urine electrolytes or urine creatinine at that time. They just went straight to dialysis. And all I can tell from the chart is for the first 2 or 3 days, they say extremely low urine output. And they don't even document how much it is. I know that drives everybody crazy, but that's all I could get. So let's try to figure out what might have happened to this guy. And we'll make the assumption, and I can tell you that his further course suggests strongly that he had acute tubular injury. What are the biggest risk factors for tubular injury? He was altered enough that there's almost no history, other than we knew his past history, and they never really figured out what happened to him. I can tell you, I saw him 8 days later, and it was unclear what had caused this episode. He was on metformin and lisinopril, which were obviously both held. Is this a situation where metformin could cause a lactic acidosis? Because we know that metformin doesn't cause lactic acidosis very often. But this is the one situation because his estimated GFR, if we could do an estimated GFR, which we really can't, but we know that to get to creatinine of 10, that would be an absolute contraindication for metformin. And the nephrologist believed that his lactic acidosis was a combination of hypotension and metformin. So I present it like this just to start out the story. Now let's see if we can guess a reconstruction. So we're worried about sepsis, and I can tell you he did not have sepsis. He was cultured. So Travis, what are you thinking? You're just waving at me?
No, I was gonna say, with his chest pain, like how many days was he, did he have chest pain first? What symptoms was he having preceding the uremia? That, I think that would be an important historical factor. Did he have diarrhea, new medication started, something like that?
As best we can tell, not. And again, he doesn't remember what happened. When he becomes more alert, and when I see him, he all he remembers is that he woke up in the ICU. The important point here is that the biggest risk factor for ATN is volume contraction. That most causes of acute tubular injury occur in the face of volume contraction. And the fact that he was hypotensive, he did respond to volume resuscitation, suggests that it may well have been that he continued taking diuretics that he was on for a preserved ejection fraction. But anyway, so he gets dialyzed 2 or 3 times, and about day 3 or 4, they start to notice that his urine output starts increasing. And he comes out to us on day 8. So all we really know is he's had a couple of successful dialyses. They've gotten his potassium under control. He's become more alert, and he's starting to make urine. And so we see him on day 8 with a creatinine of 6.9, and they decided to put a perm cath in. They'd been using just a temporary catheter. So there a couple of good questions here. So would you give him lactate ringers even with that potassium? I haven't read the article real carefully, but there's a recent article that suggests there's really not much difference between normal saline and lactate ringers. Do you believe that article? Has anybody read that more carefully than me?
Yeah, there was a lot of crossover. So a lot of patients in both of those ended up getting like a liter of saline before they were randomized. Mm-hmm. And most of all patients were surgical patients that were post-op. So, I mean, there was just way too much crossover. Someone got 2 liters. It was a liter of NS and a liter of LR. I mean, it really doesn't, I think it just wasn't really a good study.
So why would you give LR anyway?
Well, one, I give LR just to about everybody, just because, normal saline has such a high chloride content, and the hyperchloremia ends up causing, an acidosis, which causes vasoconstriction of the of the kidneys, and that just worsens everything. LR is more pH neutral. I mean, it's just a better balanced solution to use, especially when someone's acidotic. But the fear is that there's like 4 milliequivalents of potassium in it, but really it shouldn't matter. The laws of diffusion, if a potassium is 8, it's not going to go above 8. It's going to go down towards 4.
Well, it's 4 milliequivalents in a liter, so you're really giving potassium so slowly that it just is not very much. And the fact that there's lactate in it doesn't matter either, because once we volume expand the patient, they'll metabolize the lactate. Zach, I love that you're talking about post-ATN diuresis, because that's really why we're presenting this patient. So the story is that the first day he's on our service, which is 8 days after he comes into the ER, he's alert, can give a good history of what he normally is. He doesn't know what happened to him. His creatinine is 6.9. The next day, his creatinine is 7.8. He gets dialyzed again. They then put in a perm cath. And we notice, because he has one of those ducts, and does everybody know what a duct is? It's sort of a urinal that they keep at the bedside, and there's a lot of urine in there. So we can tell that he's making a lot of urine. So we start getting them to measure it, and we're getting we start out at about 1 liter a day and get up to 2 or 3 liters a day. On the day after dialysis, his creatinine is 5.4. The next day it's 6, but he's making about 1.5 liters of urine. Then it goes to 6.1, 6.2, and 6.4. Now the question is, what do you think when the creatinine is going up slowly, but they're making more urine? So Zach, if you could unmute yourself, you mentioned post-ATN diuresis. What do you know about that?
Yeah, I know after somebody has like an acute tubular injury like ATN, that kind of filtration and urine production recover before the transport mechanisms in the tubules. And so you end up spilling a lot of volume of urine, but don't necessarily kind of reabsorb electrolytes in the same way you normally would. So I know one important thing is making sure you're checking K and mag, because these people can become profoundly hypokalemic and hypomagnesiemic pretty quick.
Right. So let's go over that and make sure everybody understands that, because that was really good, Zach. And I'm gonna embellish on what you said. So what is acute tubular injury? And why do we call it acute tubular injury? It has to do with the kidney not being able to reabsorb salt and water. And back in the 70s, when I was an intern, we had a nephrologist who was an acute tubular injury expert, and there was a debate going on, and I tried to look up pathophysiology the other day as to whether the problem is that the GFR goes down and that causes the tubular injury, or does the tubular injury go down and does the glomerulus respond by shutting down so that you don't become a prune? Because if you still had a GFR, now this explains two different things, and we're gonna get to this in 1 second. This explains why the fractional excretion of sodium works in an oliguric acute tubular injury patient. It doesn't work very well and wasn't meant to work well in someone who's not oliguric. But this guy was oliguric, so if they'd gotten it, it would have been high. And so let's say you had fractional excretion of sodium of 5, which a lot of patients with acute tubular injury have. you're going to lose a lot of salt if you don't decrease your GFR, because you're going to lose 5% of the salt that you filter. Well, that's a lot of salt, and you're not going to be able to keep up with that. So the attending that I worked with suggested and had some evidence that this was the kidney's defense mechanism against that tubular injury, was to decrease the GFR. Does that make sense to people? Travis, Travis is right in the middle of my screen and he keeps raising his hand. Did you sit in the front row when you were in medical school?
I think I sat in the middle.
Okay.
I think I sat in the middle or the back, because they put you in alphabetical order. My last name is Smith, so I get stuck in the back. So now I have to overcompensate. That same mechanism I heard in a tutorial by Avi Cooper about the hyperchloremia as a mechanism of why normal saline isn't good and causes acidosis, because basically your tubules see this excess chloride load, and the macula densa sitting right there. It basically, through the feedback, tells your glomerulus like something's going on here, and it shuts down. So that's the same mechanism I've heard for the chloride as well as for the sodium.
So we know everybody has learned the fractional secretion of sodium. Some of you have heard me talk about the urine to plasma creatinine ratio before. Does anybody remember me talking about that? Let's talk about it, because let's see if I can find, okay. On, let's see, it must have been about day 5 on our service. This is his creatinine is just hanging around 6. We get a spot urine creatinine, which is 60, with a serum creatinine of 6, which is a urine to plasma creatinine ratio of 10. Now, that is a very interesting, the urine to plasma creatinine ratio is very interesting and will support a lot of what Zach said. And have you heard of this before, Zach?
No, I have not.
Okay, good. I think you'll love it. So if we assume that the kidney filters creatinine perfectly and neither secretes nor reabsorbs, which is a lie, it actually does secrete some, then the only way you can go from 6 to 60 is by water reabsorption. And so that ratio tells us how well we're reabsorbing water. If we had gotten some urine from Travis after he played golf yesterday, it was probably hot in Florida. He probably had dark urine. He would have a urine to plasma creatinine ratio of at least 100, which is, so if you think about it, you have to have reabsorbed 99% of the water that you filtered in order to have a urine to plasma creatinine ratio of 100. Or sometimes it'll be 200 if you're out there sweating and not drinking enough fluid. People with really bad acute tubular injury have very low urine to plasma creatinine ratios. And all that's telling you is that they're not reabsorbing water. Does that make sense to everybody? Did I explain that well enough? And so this guy has a urine to plasma creatinine ratio of 10. My clinical experience, I can't find this in a book, my clinical experience is people with serious acute tubular injuries have urine to plasma creatinine ratios in the 7, 8, 9, 10 range. They're really wasting water. They're not just wasting sodium, they're also wasting water. So even at this point where his creatinine has stabilized at 6, he's not he probably has an estimated GFR of around 10, we figured out roughly. But with that GFR of 10, he's putting out 1 cc per minute. And so he's really peeing a lot. Does that make sense? And so he's still at significant tubular injury. His GFR is improving, and that's why he's making so much urine. And that's really why you get that it's actually not called post-ATN, it's called diuretic phase of ATN. That's the technical phrase, the technical term. Now, this is tricky, and I've discussed this with the kidney boys several times. he says you have to be real careful not to chase that urine, especially our patient was able to drink fluids on his own. So he had intact thirst mechanism. He had no altered mental status at that time. And so you let them pee it out because patients who have oliguric acute tubular injury tend to get volume overloaded. And so you let them take care of yourself. So don't chase that urine. And I was taught to chase it when I was younger, but that's probably not the right way. I recommend you read what Travis wrote. So on day 7, as I was leaving the service, his creatinine had peaked. Now he's not been diuresed for a week now. His creatinine peaked at 6.4, and then the day after I left the service, it went down to 5.8, and the following day it went down to 5.3 without any further dialysis. And he was discharged after that. So the question, and this has happened to me twice in the last 6 months, is when you have someone, I've had 2 patients with acute tubular injury who their creatinine is not improving, but their urine output has gotten large enough that they're on the way to improvement. And so we were able to convince renal not to diurese them because the potassium was fine, they were eating fine, they didn't have any uremic symptoms. Have any of you had that type of experience or want to make any comments or have any questions about that? The last time he was dialyzed was the second day on my service, and I had him for about a week before I went off service, and he then was resolving his acute kidney injury. Does anybody have any comments about that or questions? Okay, so what do you think? What do you think happens to him? And I actually have follow up from a little bit over a month later. And actually, a week after discharge, they get another urine creatinine. Will that help us? So Thiago is going to estimate that the baseline, that it'll be between baseline and 5 a month later. So Thiago, why do you say that?
So I say that because he has chronic disease and he's 79, so it's unlikely for him to come back to his baseline, but he is improving, and I think he will continue to improve for some days or weeks.
So a week later, a week after discharge, and remember I said he had come down to 5.3, his creatinine was 3.8 1 week later. His urine creatinine now is 136. So now we have urine plasma to creatinine ratio, urine to plasma creatinine ratio of about 40. So you can see that his tubules are working better even a week later. So he's getting a nice recovery. What's interesting that I was reading about the histology and the pathophysiology. We used to use the term ATN, and I sometimes slip into that, but you don't get total necrosis of the tubules. You just get injury, and they do recover many times. What's great about this one is that he came back to see renal a month after that, and remember we said that I just call it, I'm trying to call it acute tubular injury rather than ATN. That's what the nephrologists are preferring. His bicarb, all of his labs came back to normal. It was lactic acidosis. They stopped the metformin. They gave him volume, and his lactate resolved entirely. Just a little bit over a month after that, his creatinine was back down to 1.5. So he totally recovered. Now he's at risk. He's actually not 79. I just said he was 70 something. But he was actually in the low 70s, not the high 70s. I just didn't want to use his exact age for HIPAA reasons. But he's in his early 70s. So my guess is what happened is that he became volume contracted, and if you stay volume contracted long enough, you get hypotensive, and that's what gets your kidneys. And why that happened, why he was altered, they never figured out. Was his CP anything?
His chest pain. Was his chest pain anything?
No, it didn't. He had troponins, and that didn't turn out to be anything. He didn't have an infection. We really don't know what happened to him. So he didn't have rhabdo. I think it was just hypotension. Hypotension can do this. I mean, if you stay hypotensive long enough, that's the danger of missing prerenal azotemia. Is if you don't treat prerenal azotemia, it converts to acute tubular injury. So this was a happy story because he totally recovered. I think to me there's several lessons, and then I'm going to ask you all to say what you think your big lessons are. The first lesson is how dangerous volume contraction is, and we don't really know why he got volume contracted and hypotensive, but the case that we presented a few weeks ago, I guess 4 weeks ago, was a case of a guy whose creatinine was increasing because he was volume contracted, but we couldn't figure out that he's volume contracted because he also had heart failure, and it was just very, very confusing. And trying to diagnose volume contraction is difficult, but we just can't afford to miss it. So that's the first thing. The second is, I don't think a urine chloride would have helped. To me, the urine sodium and the urine creatinine when he came in would have been very interesting. The only time he had concentrated urine was the first urine they got. So his urine specific grade is 1.020. I looked, they did subsequent urinalyses, and it was always around 1010, which is about what you get with acute tubular injury. You get sort of a bland urine. They didn't look for muddy casts, but he just clinically had acute tubular injury. The next thing is that you need to watch and understand what Zach was talking about the diuretic phase of acute kidney injury. He was fortunate that he went into the diuretic phase within a week. I've seen people take 3 or 4 weeks, and some people don't recover. And the last is the instinct that several of you had that he was not going to get back to normal. We now know that having an acute tubular injury is a risk factor for more progressive chronic kidney disease, and he does need to be followed by renal. He is being followed by renal. What's interesting is despite having a hemoglobin A1C of 10, having a slightly elevated creatinine, he doesn't have any significant protein in his urine. Renal still wants to put him on an SGLT2 because I think renal wants to put everybody on SGLT2. And I can't, that probably would be a reasonable thing to do to help with his control, because you don't want to put him back on metformin now that he's had that episode of lactic acidosis. Even though I think metformin is a very safe drug, SGLT2s are much safer, and he's in a healthcare system where it won't cost him anything to be on SGLT2. So Thiago, that I love that point. So could you explain that point to everybody, because we all need to remember that all the time. So Thiago, if you could explain the diuretic mechanism of SGLT2s and why you have to be very why you have to be very careful when you start them. I think you're
Yeah.
muted. Yeah, there you go.
Yeah. So SLD2 inhibitors, they are being used more and more. So there is this study, DAPA-CKD, showing renal benefits, but it is, as it will put glucose inside the tubules, it will cause osmotic diuresis. So people who take SGLT2 inhibitors, they have increased urine output, and this is a biggie. This is good for the drug because it can be used for heart failure. So there's the results for heart failure, especially decreasing the hospitalization, is related to this osmotic diuresis because more glucose will be inside the urine, taking water with them. As Travis is saying, it also helps with weight loss. But I was just wondering because we like to use SGLT2 inhibitors for those who have diabetes and coronary artery disease and chronic kidney disease and heart failure, even with preserved ejection fraction, because we've just seen 5 days ago results from the study of empagliflozin with heart failure and preserved ejection fraction, showing that it's a good drug. So it looks like it will be the first drug to treat heart failure with preserved ejection fraction. So this is a great guy, a great candidate to receive this drug, but we know he will increase his urine output. So I was just wondering about it because you were afraid of this. We don't know what went on. We don't know what happened, but you suspect that hypotension and volume depletion played an important role. So knowing that, I would be afraid of giving him a drug like this one. This is what I went to my mind. And also keeping in mind that it can cause euglycemic diabetic ketoacidosis. So this drug, you have to be aware of genital infections because of glucose in the genitals, euglycemic ketoacidosis, and volume depletion because of osmotic diuresis.
So, and I'm just going to expand on that. There's actually two mechanisms of diuresis because SG stands for sodium glucose. And so you're blocking sodium reabsorption in the proximal tubule. So you're getting both a salt diuresis and an osmotic diuresis. And the danger, and if you want to hear this explained much better than I can explain it, the podcast that I did for Animals on Call on the SGLT2s, and I did a couple of them, the woman that I interviewed, Kathy Tuttle, who's both an endocrinologist and a nephrologist, explained this. She says that if you start an SGLT2 and they're on a diuretic, you need to be careful about the diuretic dose. You need to be very careful about the diuretic dose. The other thing that she pointed out is, as best as you can tell from the studies, just being on an SGLT2 is good for both proteinuric kidney disease and for heart failure. It's not as good for coronary artery disease as GLP-1s are. So if you primarily have a diabetic with coronary artery disease and they don't have heart failure, GLP-1s are probably preferred because they improve outcomes more with coronary artery disease. The SGLT2s improve it for all heart failure and for kidney disease. They are expensive. Fortunately, the VA has made it an available drug for all the veterans. But if you have a heart failure patient who's on diuretics and you start an SGLT2, you need to be very careful and see them back very soon and make sure they're not getting over diuresed. So the point that Thiago is making is an extremely important one. that you have to know that you're giving that it has a lot of different effects, and one of them is a diuretic effect, and that diuretic effect exists both in people with diabetes because they're excreting more glucose, and in people without diabetes who get it because it's now indicated for heart failure without diabetes, or for proteinuric kidney disease without diabetes. And so we just have to understand that when you're giving this drug, it's not just glucose lowering. And so that, Thiago, thanks for bringing that point. And I hope that was okay that I mentioned the sodium diuresis. So you deliver more sodium. So if you're already on a loop, you're going to enhance the loop diuresis. Does that make sense to everybody? And I think that the GLP-1s are particularly better for weight loss than the SGLT2s. At least that's what I've read. So do I have that right, Thiago?
Oh, thank you. Thank you for teaching me more about the diuresis, because, I'm so focused on diabetes treatment and when to choose the drug. And thank you for this mechanism.
Well, it helps to remember that SGLT2, it took me a while to learn this, is sodium glucose transporter. And so you're blocking both sodium and glucose. So I hope everybody learned something. Lindsay, maybe you could tell us what your big take-home points are.
Yeah, I think my big take-home point is let me make sure I get your name right. Was it Joel? Is that right? Sorry, I'm scrolling back. Zach, I'm sorry, Zach. What Zach said about the post-ATN diuresis, I hadn't heard that before, or thought about it, or looked into it very much. So thank you for that. And then the urine plasma creatinine ratio, that was a first for me, and how to use it. I think that's the big points I took away.
Okay, does anybody else have any major points? Zach, since you spoke up, what did you get out of this?
I thought the urine plasma to creatinine ratio was pretty useful. I never heard of that used before, and it seems like a pretty useful marker of, assessing the kidney's ability to reabsorb water.
Yeah, it's very old school, but then so am I. And Drew, you always learn a lot. What do you want to take out of this?
I think for this, I'd probably take home the point that once you have someone who's diuresing and you're getting them to the point where their creatinine's going lower and lower and lower and lower and lower. The fact that if they're starting to get urine out, that's a good sign that they're sort of in like the recovery phase of ATN, and that'll probably recover, I guess.
Yeah, and it's interesting that the two patients I've had in the last 6 months who did have acute tubular injury seemed to plateau for about 4 or 5 days, and every day was kept on saying, well, they're making a lot of urine, the creatinine's going to come, they're making a lot of urine, the creatinine's going to come down, and then all of a sudden on the 4th, 5th, or 6th day, all of a sudden the creatinine does go down. But waiting for the creatinine to go down, you should be happy when it's not going up, is what these two patients have taught me. I'm going to let Travis have the last word.
You're too kind. I think, I get so caught up in, the acute stuff and, seeing these uremic patients come in needing emergent dialysis, seeing kind of how on your end, what you guys look for and the medications and the discharge follow-up is always something that continues to intrigue me and great to learn from everybody on here. So thanks, Thiago and Lindsay and you, Dr. Centaur, appreciate it.